All right, class, can you hear me? I think you can hear me. Um, Bismillah ar-Rahman ar-Rahim. Well, my name is Dr. Asad, and today we'll be studying about esophagitis, specifically reflux esophagitis, Barrett's esophagus, and uh, two most common malignancies of the esophagus, that is squamous cell carcinoma and adenocarcinoma, and the association of Barrett's esophagus with adenocarcinoma of the lung, of the esophagus. So just a quick overview. The histological structure of the esophagus is that it is lined by the stratified squamous epithelium, which is there to protect against the friction of the food that passes by. And esophagus has very little absorptive function. So its main function is it acts as a conduit for the food. So it's lined by stratified squamous epithelium, which is optimized for friction or passage of food. Then the esophagus has a very rich supply of lymphatics in the lamina propria. So it has a fairly large and strong supply of lymphatics, and we'll see why this becomes very important in different parts of the gastrointestinal tract, so much more in the esophagus, because as soon as the tumor breaks through the basement membrane, it can spread into the lymphatics and then go have distant metastasis and lymph node metastasis. So this is really important, that the lamina propria or the connective tissue just below the epithelium is very rich in lymphatics. Then there is the muscular layer. There's a very fine or almost non-existent muscularis propria. Then there's a submucosa and muscular layer, and then finally there's the adventitia. The serosa is not covered by the serosa. It is not a peritonealized surface. It contains at the periphery loose connective tissue. And then again, this is an important anatomical barrier in terms of tumor spread. So it has the adventitia. Now, there are some minor salivary gland tissue that help produce mucus material. So passage of food is facilitated, but by and large, it is all stratified squamous epithelium. All right. Okay. So just a quick overview once again. Gastrointestinal tract is a hollow tube including the oral cavity, esophagus, stomach, small intestine, colon, rectum, and anus. The oral cavity portion was covered in your lectures by Dr. Amna. The whole gastrointestinal tract functions to regulate the intake, processing, and absorption of the ingested nutrients. And ultimately, what is absorbed is taken into the blood, and the rest of it is disposed as waste products in the form of feces. So now, reflux esophagitis. Reflux esophagitis is a complication or is a disease in which basically what happens is contents of the stomach start to regurgitate or spill over backwards or reflush into the esophagus. Now, the esophagus, as I told you, is optimized for the function of passage of food. यानी कि खाना उसमें से बहुत आसानी से निकल जाता है. But what it is not optimized for is low gastric pH, low pH, because food quickly passes. So the epithelium it's very resistant to the friction, but it is very sensitive to acid damage because it's not optimized. There's very little mucus glands to buffer the acid. So whenever there is a problem in the stomach in terms of high pressure, or there's a problem with the lower esophageal sphincter, or a combination of both, the acid refluxes or regurgitates into the esophagus. And when this keeps on happening over a long and sustained period of time, it can cause damage to the epithelium of the esophagus. So what protects against this reflux is basically primarily the tone of the lower esophageal sphincter. And because it keeps it close, so what happens is gastric reflux or gastric acid does not spill over into the esophagus. Reflux of gastric contents into the lower esophageal sphincter is the most frequent cause of esophagitis, obviously, because that is the main barrier that is stopping stomach acid from regurgitating into the esophagus. It is a very common outpatient GI diagnosis in the United States. Not only in the United States, even in our part of the world, reflux esophagitis is a fairly common problem. And the severity can vary from very mild to very severe, as we'll see in the subsequent slides. Associated clinical condition is termed as gastroesophageal reflux disease. Okay, I think that's it. Most common cause of reflux or problems with the reflux is that there is transient lower esophageal sphincter relaxation. So the sphincter at all times is not constricted. It is slightly open. That allows for the reflux or the splashing of the gastric contents into the esophagus. Reflux of gastric juices is central to the injury of gastroesophageal reflux disease. As I told you, that the epithelium of the esophagus is not optimized. It is not because it's stratified squamous epithelium, and the most optimum epithelium for managing or managing the low pH or the strong acid environment of the stomach is columnar epithelium. Any condition that decreases lower esophageal sphincter tone or increased intra-abdominal pressure contributes to GERD. So sometimes in conditions that predispose you to have a strong or increased intra-abdominal pressure chronically will predispose you to have GERD. And in conditions where the patient has only mild lower esophageal sphincter dysfunction and has some complaint or some situation or some disease or some condition that increases the intra-abdominal pressure, will then predispose you to develop GERD. See? So one of the common examples of physiological phenomena that can cause increased intra-abdominal pressure is pregnancy. So that is why a lot of during pregnancy, especially in the second and third trimester, women will complain of increased symptoms of GERD because there's constant increase in abdominal pressure. Chronic constipation, a tumor in the abdominal cavity, all these can predispose you to develop GERD or can worsen the symptoms of GERD. Okay. I'll just take a moment. If any of you have a question, please raise your hand and let me know. If I'm going too fast or I'm going too slow, please message me or I'll give you a moment and then I'll proceed further. Okay, I think there is no question as of it, so I'll proceed. Okay. Now, alcohol and tobacco use, obesity, central nervous system depressants, pregnancy, hiatal hernia, delayed gastric emptying, and increased gastric volume all predispose you to develop gastroesophageal reflux disease. Alcohol and tobacco directly because they cause damage to the epithelium and they cause increased acid secretion, especially tobacco. Obesity, as I told you, because it consistently causes increased intracranial pressure. Okay, my sound is not appropriate. Okay, just give me a moment. Is it better now? Okay, I hope so. Okay, so obesity, what it does is it increases the intra-abdominal pressure that can precipitate or exacerbate the reflux. Secondly, central nervous depressants, what they do is basically they activate the basically vagal system, which causes increased acid production, and it can also alter the resting esophageal tone. It can decrease the tone, so that predisposes the gastric contents to regurgitate into the stomach. All right. Besides that, oh, sorry. Yeah. And obviously, delayed gastric emptying or increased gastric volume will also increase pressure within the stomach and then cause regurg of the acid. And unfortunately, in a lot of cases, there's no definitive cause, and the patients, if we treat them with in a generic fashion. Now, gastroesophageal reflux disease is most common in individuals older than 40 years, but no is exempt. And we are seeing increased cases of reflux disease in even younger individuals. Most frequent clinical symptoms are heartburn, dysphagia, and regurgitation of sour tasting gastric contents. Now, this is a fairly common complaint, and the patient will commonly come to you with coming to you saying or complaining that डॉक्टर साहब जब मैं सुबह उठता हूँ तो मुंह कड़वा महसूस होता है, and that is a hallmark or very characteristic finding of the gut because of the increased regurg. What happens is because it's the acid content is sour, so you have sour tasting and kadwa kadwa muh subah uthte hain. They a lot of patients, they come with problems with the with mild laryngitis. They'll keep on coming with reflux, with chronic cough, which will mimic allergic cough. So this is important. Sometimes the patient may complain of a slightly or present with a slightly different presentation, and that is because they have reflux when they're lying down, which causes easy passage to the gastric contents into the esophagus. So an easy advice that you might give them is use two pillows or raise the edge of the bed, so it causes a slant and reflux becomes slightly more difficult. That's one of the approaches to advising these patients. Now, complications of reflux esophagitis include ulceration, obviously, because of increased acid. In very severe cases and in very long-standing and chronic cases, or especially patients who are also taking alcohol or smoking heavily, the patients may have hematemesis, that is blood in the vomit. Um, Obviously, if the bleeding is very subtle or very small, or the ulcer is small, and only it's a very slight process, what happens is it bleeds and the blood passes into the stomach, and ultimately it gets digested and it passes into the feces. That's why it presents as upper GI bleed or melena, that is black stools. So melena is basically black stools, and it is a sign that the bleeding is probably taking somewhere in the upper gastrointestinal tract, because if it's in the lower gastrointestinal tract, generally they present with bleeding PR. So melena is a hallmark of bleeding somewhere in the upper gastrointestinal tract. Okay. And stricture formation, obviously, if the ulceration is deep enough, it's chronic enough, ultimately, as you know, healing by chronic inflammation is always by fibrosis. So fibrosis or strictures can develop within esophagitis, with reflux esophagitis. Although this is fortunately enough, it's a rare complication. And the most dreaded complication of reflux esophagitis is Barrett's esophagus. And Barrett's, if we'll see in the next subsequent slides what Barrett's esophagus is. But because Barrett's esophagus is very important because it is a precursor lesion. It is metaplasia of the intestinal esophageal epithelium, and it predisposes you to develop adenocarcinoma of the esophagus. Okay. Now, hiatal hernias can also give rise to symptoms that are similar to GERD, and one of the reasons is basically what happens is in hiatal hernia, as part of the gastric cardia protrudes um, into the thoracic cavity. See, it's a small portion, but what happens is, if you remember anatomy, the anatomy of the lower esophageal sphincter was such that one of its support structures was the diaphragm. It's adhered to the diaphragm. The diaphragm gives it support. Now, what happens is when the portion of hiatal hernia where gastric cardia goes up, what happens is the esophageal sphincter, it moves up so very slightly, and because of it moving up, what happens is the support from the diaphragm is lost, and it then functionally what happens is the lower esophageal sphincter is slightly the tone of the lower esophageal sphincter is slightly lost, and that facilitates the reflux of gastric contents into the stomach. Obviously, the bigger the hiatal hernia, the stronger the symptoms of reflux will be there. But generally, um, um, it predisposes you to develop hiatal hernia, predisposes you to develop gastroesophageal reflux disease. Hiatal hernia is symptomatic in fewer than 10% of individuals, but can be cause of lower esophageal sphincter incompetence, as I just told you. Now, Barrett's esophagus, one of the most dreaded complications of reflux esophagitis. Intestinal metaplasia within the esophageal squamous is what it's defined as, is intestinal metaplasia within esophageal squamous mucosa. It is a complication of gastroesophageal reflux disease, and it is seen in about 10% of patients who have gastroesophageal reflux disease. So it's not a very common complication, but it's not a very it's not that uncommon also. But so the most important thing is because it's a precursor lesion, so it can patients with Barrett's esophagus can go on to develop adenocarcinoma. Now, when we discuss the histology, there's some controversy regarding the definition of Barrett's esophagus, and I'll tell you both the American uh, what the Americans define Barrett's esophagus as, and the British define Barrett's esophagus, and probably down the line we'll tell you what will probably become the mainstay. It is, as I told you, it is important to identify or catch patients in this Barrett's esophagus stage, because a subset of these populations, if not treated or not managed appropriately, may progress to adenocarcinoma of the stomach. Okay. So this is Barrett's esophagus, and it's defined as red velvety mucosa at the distal end of the esophagus. See, so red velvety. Normally, the epithelium of the Barrett's esophagus is stratified squamous epithelium. It is pale pink. So it has a slightly lighter tinge to it, and this, because the epithelium is intestinalized, so this gives the look of velvet or rough, जैसे ना विलाय वाली look आ जाती है, तो it gives this velvety look, सही है, and pink salmon colored, that's a classic description of Barrett's esophagus, salmon colored mucosa or red velvety mucosa. Okay, so this is the normal esophagus. You can see the stratified squamous epithelium, pale esophageal lining, and this is the gastric lining. And what you can see is this lower esophagus is being intestinalized, so it loses this pale color and becomes red velvety or fleshy. See, and these are the gastric dural folds. And what we see under the microscope is stratified squamous epithelium, and at the gastroesophageal junction or in the esophageal biopsy, we see these goblet cells. So this is intestinal metaplasia. So what happens is basically from a physiological, from a histological point of view, what happens is the esophageal lining, it tries to become more adaptive to the decreased pH, and because decreased the epithelium, which is more optimized to deal with the decreased pH or the increased acidic environment, is the columnar epithelium. So this epithelium becomes intestinalized, or it undergoes columnar metaplasia or intestinal metaplasia और goblet cell metaplasia. ये सारी terms यूज होती हैं Barrett's esophagus की histology को define करने के लिए. And these cells that you can see this barrel-shaped or vacuolated cytoplasm, these are the goblet cells. Now, there are two components for the diagnosis of Barrett's esophagus. एक तो ये कि you see the red velvety mucosa on the endoscopy, and that is the first part, because we need to be sure that the biopsy or the sample has been taken from the esophagus and not from the stomach, because stomach itself can also show intestinal metaplasia. So first of all we need to be sure that we have taken the biopsy, or what we are looking at is the esophagus. And when we see metaplasia in the esophagus, we label it as Barrett's esophagus. So थोड़ी सी controversy है वो ये कि the Americans say we need to see goblet cells. The Britishers say no, if the endoscopist is sure that he has taken the biopsy from the esophagus and we see any columnar mucosa, we will label it as Barrett's esophagus. So थोड़ा सा difference है. The Americans, the definition includes presence of goblet cells, only columnar mucosa will not suffice for diagnosis of bad esophagus. The Britishers say no, we have to see uh, uh, red velvety mucosa on the endoscope and a columnar mucosa. Goblet cells are not necessary. And what uh, what I believe and what the general experienced pathologists believe is probably the British system is more appropriate and it's more accurate, and probably down the line, by the time you guys come into clinical practice, probably that will be the proper definition. But as of yet, for your level, you need to see red velvety mucosa on the endoscope and goblet cells on the microscope. All right. And obviously, for to confirm, only endoscopy is not sufficient. You also need to see uh, uh, goblet cells under the microscope. Obviously, as we know that prolonged metaplasia in case of esophagus, in case of reflux esophagitis, will give to rise to esophagus, and if unhampered in a subset of patients, this will give rise to dysplasia and ultimately carcinoma. So intramucosal or invasive carcinoma requires therapeutic intervention. So once we know that dysplasias arise, um, there is some uh, role, or there's debate, especially with high grade dysplasia, that we need to treat the high grade dysplasia, and there are techniques of removing the mucosa through photoablation or through mucosal dissection, that you strip off the mucosa and hope that the dysplasia or the problematic epithelium is taken care of. Whenever you have high grade dysplasia, with low grade dysplasia, generally the trend is you follow it with repeated endoscopies. But if you get high grade dysplasia, generally the the idea is that you treat it with either mucosal ablation or mucosal resection. And I'll just show you some videos after I cover the lecture, how these are managed. Options include surgery as well as newer modalities such as photodynamic therapy, laser ablation, and endoscopic mucosectomy. Now, I have some videos, and I will cover those or play those videos for you at the end of the lecture. Now, coming to esophageal tumors. Now, this is just a list of the tumors that can be seen in esophagus, but for all practical purposes, these two, squamous cell carcinoma and adenocarcinoma of the esophagus, are the ones that are our main concerns. But the other tumors, carcinoid, melanomas, lymphomas, lipomas, these are fairly uncommon. Sometimes you do see leiomyomas also. An important thing is, we'll cover this when we cover stomach tumors. But what you need to remember is that uh, all along the gastrointestinal tract, the two more common gastrointestinal smooth muscle tumors of the smooth soft tissue are leiomyomas and cysts. Esophagus is one area where leiomyomas are more common as compared to gastrointestinal stromal tumors. Elsewhere in the gastrointestinal tract, whenever you see a mesenchymal tumor or soft tissue tumor, it is the common tumor is gastrointestinal stromal tumor. In esophagus, the more common smooth soft tissue tumors are leiomyomas. Okay. Now coming to adenocarcinomas. It's a direct, or it's a complication of Barrett's esophagus, and because the epithelium has undergone columnar metaplasia or goblet cell or intestinal metaplasia, so that epithelium undergoes dysplasia, and ultimately it can give rise to adenocarcinoma. Esophageal adenocarcinomas usually arise in setting of Barrett's esophagus. Other risk factors include tobacco use and exposure to radiation. So it's common in smokers, especially patients taking pan and tobacco. Uh, you can see in some patients you can see adenocarcinomas. Obviously, it's the tobacco association is far more in cases of squamous cell carcinoma. Okay. Conversely, risk is reduced by diets rich in fresh fruits and vegetables, and this you will see this as a recurring phenomenon all along the gastrointestinal tract, and some serotypes of Helicobacter pylori. Now, this is very important and interesting because what happens is some strains of Helicobacter pylori, what they do is they cause decreased secretion of acids in the stomach, and that protects, sort of gives you a protection against recursion. Because as you remember, the central problem in Barrett's esophagus was reflux esophagitis. तो अगर एसिड की कंसंट्रेशन कम हो जाएगी तो जो कंटेस्टेंट्स रिफ्लक्स कर रहे हैं उनके जो पीएच है वो कम हो जाएगी, उस एसिड की स्ट्रेंथ कम हो जाएगी, स्ट्रेंथ कम होगी तो डैमेज कम कॉज करेगा. तो सम टाइप्स सम स्ट्रेन्स ऑफ हेलिकोबैक्टर पाइलोरी, what they do is they decrease the gastric acid secretion, and that gives you some protection with esophagitis. So sometimes treating those patients, if those patients have Helicobacter pylori gastritis also, what happens is it gives you some protection against reflux esophagitis, but it's not always true, and obviously it's better to eradicate the Helicobacter pylori and then treat for reflux separately. Generally, what you do in a reflux esophagitis treatment is you give acid suppression drugs like omeprazole or the proton pump inhibitors, and then you give some agents that increase gastric motility. So that is the rationale of using drugs like motilium, because it increases gastric emptying. So instead of regurgitating, the acid is passed into the intestine. So that is the mainstay or the rationale of treating with these diseases, these drugs in reflux esophagitis. Obviously, it is adenocarcinoma of the esophagus is more common in Caucasians of white population. It is sevenfold more common in men. The incidence varies widely worldwide, with highest rates being in the US, UK, and Canada, Australia. Obviously, areas where there are more Caucasian population, and it is lowest in Korea, Thailand, Japan, and Pakistan. Fortunately enough, in Pakistan also the incidence is not that high. Okay. Progression of Barrett's esophagus to adenocarcinoma occurs over time with stepwise acquisition of genetic and epigenetic changes. So generally the morphological progression is intestinal metaplasia, followed by low-grade dysplasia, then high-grade dysplasia, and ultimately adenocarcinoma. Molecularly, what happens is there are mutations of the p53 gene, which is the tumor suppressor gene, followed by then downregulation of cyclin-dependent kinase inhibitor CDKN2A, which is also known as P16. And you will see this P16 then again. It's one of those genes which is frequently associated with a lot of tumors in other sites also. So what happens is these systems, these protective systems, they are hit first, and mutation occurs early on in the P53 and P16 genes, which gives environment where other mutations can occur easily because they are tumor suppressor genes, and ultimately with these will progress to more mutations being avoided by the neoplastics or the dysplastic cells, and ultimately progress into carcinoma. Okay. Besides P53 and P16 gene mutations, you can have mutations of EGFR. This ERB2, or also known as ERB2 or HER2/neu. So there's this mutation is shared by the breast cancer also. That is why HER2/neu is also, Herceptin is also given as a therapy for adenocarcinoma of the esophagus. MET gene, cyclin D1, cyclin E gene mutations are also picked up late in the tumorigenesis. Commonly, these patients will have long-standing history of GERD or GERD-like symptoms, and they will present with difficulty in swallowing, obviously because of stricture formation or narrowing down of the lumen, progressive weight loss, metamesis, chest pain, or vomiting. Chest pain you generally see in conditions where unfortunately the tumor has spilled over into the adventitia and spread. Now, coming to squamous cell carcinoma. The risk factor list is fairly long, with alcohol and tobacco being the more well-known or well-established risk factors. But besides that, poverty, caustic esophageal injury, eclasia, tylosis, lumbar syndrome, diets that are deficient in fruits or vegetables, frequent consumption of very hot beverages, and previous radiation to mediastinum because of either generally thymomas or lymphomas of the mediastinum are treated with radiation. So these patients are at risk for development of squamous cell carcinoma. Okay. Any questions? Now, incidence varies up to 180 folds between countries. So there are regions which have very high incidence of squamous cell carcinoma, like Iran, Central China, Hong Kong, Brazil, South Africa, even within Pakistan, the belt along the border of Afghanistan and Iran, they have higher incidence. Um, Incidence is fairly high in the southern part of Sindh also because of this betel nut and tobacco chewing. Because tobacco is a known risk factor. Pockets of extremely high incidence are also seen in Western Kenya with patients younger than 30 years. And that is true because they take this special kind of uh, um, drink, hot beverage, which is it's a fermented drink, and that has toxins that predispose you to develop squamous cell carcinoma. Okay. As I told you, most cases are linked to use of alcohol and tobacco. Nutritional deficiencies, polycyclic hydrocarbons, nitrosamines, fungus, and fungus contaminated foods also predispose you to develop squamous cell carcinoma of the esophagus. Another important, and then this you will see this elsewhere also, human papillomavirus infection. So wherever there is stratified squamous epithelium, human papillomavirus increases or is associated with squamous cell carcinoma of those sites. So cervical esophageal carcinoma, cervical carcinomas, oral cavity carcinomas, laryngeal carcinomas, esophageal carcinomas, even some states of or some forms of squamous cell carcinoma of the skin, or all have an association of human papillomavirus infections. Obviously, it's not the strong association isn't strong as you see in cervix, but still it's still there. Half of the squamous cell carcinomas occur in the middle third of esophagus. Now, this is important. The gastric, the adenocarcinomas of the esophagus were occurring more in the distal half, distal third, or at the gastroesophageal junction, because that was the site of Barrett's esophagus. But squamous cell carcinomas, they tend to occur in the higher portions of the esophagus. And obviously, spread is rapid, and even a very minimal spread is disastrous because of, as I told you in the beginning of the lecture, because of the rich network of the lymphatics. Lymphatic network बहुत rich होता है, so the moment the tumor breaks through the basement membrane, it has access to the network. It spreads to the lymphatics, and then it spreads to the mediastinum, to the upper neck. Else, widespread metastasis is fairly common at times of diagnosis. Obviously, sites of lymph node metastasis vary according to the location of the tumor. So upper third tumors favor cervical lymph nodes, middle third favors the mediastinal and paratracheal lymph nodes, and the lower thirds tumors spread preferentially to the gastric and the celiac lymph nodes. Patients commonly present with dysphagia, obviously, because of the narrowing, odynophagia or obstruction and debilitation due to bad nutrition and effects of the tumor itself are common. Iron deficiency anemia is often present, occasionally may present with aspiration of food via tracheoesophageal fistula. As I told you, this is probably an adenocarcinoma of the stomach, of the esophagus, because you can see this is the gastric epithelium, this is a pale esophageal epithelium. So the tumor is at the junction, so this is probably adenocarcinoma, and this is all esophagus, and it's occurring in the middle part. This is probably squamous cell carcinoma. Okay, so it's occurring in the middle third. This is at the junction. And histologically, squamous cell carcinoma will be composed of stacking up of the neoplastic stratified squamous epithelial cells, which are dysplastic and have anaplasia, and adenocarcinoma will show gland formations. These are the gland lumina. Okay. Now I'll just play two quick videos. Or part of the videos.
Now we will.
See, this is the tongue. I'll just skip to the part. This is all esophagus, the pale, and this is, if you can see, I'll just pause it. एक second. Can you see this? This is probably some evidence of reflux. थोड़ा सा epithelium की color change हो रही है. Or probably this is the start of this is the gastroesophageal junction, and this is the stomach. This is stomach. You can see the rugal folds. See, this is normal endoscopy. This is how it's supposed to look like. See the abrupt transition from the squamous epithelium to the gastric epithelium. See, this is small intestine. These are the gastric rugal folds. So this was the area I was really interested in showing you. See, this is normal stomach, and the pale epithelium was esophagus. Now, if we look at Barrett's esophagus, I'll share the video link also. This is a nice lecture overview of what we've done, just seen. So you can also take a look at this. I'll just show you. So this is Barrett's esophagus. See, these are the rugal folds. The stomach is down, way down there. All right, and this is the red velvety mucosa, and this is the pale squamous epithelium. सही, तो endoscopy पे इस तरह की red velvety mucosa दिखेगी, and when we'll take the biopsy from here, if we see columnar mucosa or goblet cell metaplasia, that we label it as Barrett's esophagus. And the most serious complication of Barrett's esophagus is squamous cell, adenocarcinoma of the esophagus. I'll share the videos, and I'll share they are YouTube videos, so I'll share the links at Modo, and I'll upload this presentation also. If you have any questions, I am open for them. एक second, कहाँ गया भाई? Zoom. एक मिनट. हाँ, Yusra, अगर आप, I'm open for questions. जी हाँ
जी सर, एक मिनट में करती हूँ.
जी roll number 47. You had a question. You had raised your hand.
सर हेलो.
हाँ जी बेटा.
सर मुझे बोलना था, आप जो भी बता रहे थे कुछ नजर नहीं आ रहा था.
क्या उस, अच्छा वीडियो का?
जी सर.
अच्छा, वो मैं वीडियो अपलोड कर दूंगा, सही है, और वो तुम लोग देख लेना दोनों तीनों वीडियोस. अच्छा, उसमें देखो ज्यादा एंडोस्कोपी के बहुत ज्यादा शौक में मत जाना, वो क्योंकि उसमें ना वो जो पहली वीडियो है उसमें पूरी मतलब अपर जी एंडोस्कोपी ना, तो उसमें वो स्मॉल इंटेस्टाइन में भी आएगा, स्टमक में भी जाएगा, तो फोकस अभी वहीं पे एसोफेगस वाले पोर्शन में रखना, सही है. जब स्टमक वगैरह में आएंगे तो खुद कवर करवा दूंगा तुम लोगों को, सही है. और लाइकवाइज समझ में ना आए तो यूर फील फ्री टू आस्क मी, यू कैन आस्क मी द क्वेश्चन, सही है. तो जब हम रिवाइज लेंगे तो यू कैन आस्क मी द क्वेश्चन. ओके, अभी लेक्चर में कुछ क्वेश्चन है? ओके, रोल नंबर 49, यू हैव अ क्वेश्चन.
अस्सलाम वालेकुम सर. सर आई हैव अ क्वेश्चन. सर आपने जो ब्रिटिश और यूएस का सिस्टम का डिफरेंस बताया था इन द स्टार्ट, सर तो उसमें पूछना था कि जो ब्रिटिश वाला सिस्टम बताया था आपने, जिनको डिफाइन किया हुआ सर, तो वी डोंट हैव टू डू बायोप्सी फॉर दैट, वी जस्ट एंडोस्कोपी से.
नहीं, बायोप्सी तो करनी है, क्योंकि देखो होता ये कि अगर वो इंटेस्टाइनल मेटा, कभी कभार लाजमी नहीं है कि वो आपको राइट, क्योंकि ये तो मैं तो जो तस्वीरें दिखाई हैं बहुत क्लासिक केसेस की है ना, मगर हमेशा ऐसा नहीं होता कि, और फिर देन अगेन इट्स अ प्रोग्रेशन ना, वो आहिस्ता आहिस्ता बढ़ता चला जाता है. तो बायोप्सी तो करनी जरूरी है. उसकी दो वजह को आते हैं. एक तो ये कंफर्म करने के लिए कि वो मेटाप्लेजिया यानी कॉलमनर चेंज या इंटेस्टाइनल मेटाप्लेजिया हो रहा है कि नहीं हो रहा. इवन फॉर द ब्रिटिशर्स यू नीड टू सी कॉलमनर एपिथेलियम.
Okay.
But you don't. It's not necessary to see goblet cells. Varicose
Sir,
कहते हैं goblet cells.
Sir, the gold standard would be the biopsy.
biopsy from mucosa that looks like Barrett's on the endoscopy.
Okay, like जो red velvety surface से लेके
उसकी वजह ये है कि देखो अगर जो नॉर्मल गैस्ट्रोएसोफेजियल जंक्शन है वहां पर भी कॉलमनर एपिथेलियम होती है ना स्टमक की. अगर कोई वहां से बायोप्सी लेके भेज देगा तो वो तो हर चीज को बैरेट्स बना देंगे. तो इसलिए ये बहुत इंपॉर्टेंट है कि आप ये श्योर हो कि मैंने स्टमक एसोफेगस से बायोप्सी ली है.
अच्छा, ठीक है सर, थैंक यू.
दूसरा क्वेश्चन ये इंपॉर्टेंट बायोप्सी लेना ये होता है कि मैंने जैसे कहा कि खाली बैरेट्स कोई प्रॉब्लम नहीं है. प्रॉब्लम है डिस्प्लेजिया, और वो डिस्प्लेजिया से माइक्रोस्कोपिकली कंफर्म हो सकता है. वो ग्रॉसली आप नहीं बता सकते. सही है ना, इसलिए बायोप्सी लेना जरूरी होती है.
ठीक है सर, थैंक यू सर.
सही है. अच्छा, एनी अदर क्वेश्चन? ये रोल नंबर 3 क्या कह रहे हैं सर, कैन यू रिपीट द माइक्रोस्कोपिक फाइंडिंग्स ऑफ बोथ इसोफेजियल. देखो इसोफेजियल ट्यूमर्स की दो मेन वेरिएंट्स हैं. जो स्क्वामस सेल कार्सिनोमा की वो है ऐसा, ये ना तुम लोग एक बार रॉबिन से बेसिस से गो थ्रू कर लेना. मैं बेसिस का अगर मुझे मौका मिलता है तो मैं उसकी सॉफ्ट कॉपी भी अपलोड कर दूंगा एडमोडो पे. सही है. या मैं उसका लिंक शेयर कर दूंगा. यू कैन डाउनलोड इट आल्सो इफ यू फॉर द सॉफ्ट कॉपी. तो नेक्स्ट टाइम ये कि जब तुम लोग पढ़ रहे हो या लेक्चर चल रहे हो तो यू कैन इवन हैव दैट सॉफ्ट कॉपी ओपन विद यू इफ यू डोंट हैव द हार्ड कॉपी विद यू. But esophagus, देखो squamous cell carcinoma like everywhere else in the body will show you dysplastic or anaplastic squamous cells. जो cells हैं वो एक दूसरे को stack up कर जाते हैं. They have abundant cytoplasm. They have pleomorphic nuclei. Depending whether it's keratinizing or non-keratinizing, they will have abundant eosinophilic cytoplasm and will produce keratin. सही है. तो अब तुम लोगों को जो अभी जैसे इसोफेज तुम लोगों की जो प्रैक्टिकल हुआ होगा अभी ओरल कैविटीज का, उसमें भी स्क्वामस सेल कार्सिनोमा करवाया होगा. Adenocarcinoma, like elsewhere, everywhere in the body, it will form glands and it will produce mucin. सही है. तो mucin and gland formation together is important for diagnosis of adenocarcinoma, and keratin pulp formation and intracellular bridges are important for esophageal carcinomas. अच्छा, अगर कोई प्रॉब्लम है इनकी हिस्टोलॉजी में तो जब हम रिवीजन करेंगे तो मैं इनकी स्लाइड्स अपलोड कर दूंगा, तुम लोग को इमेजेस भी दिखा दूंगा. वी कैन आल्सो हैव अ डिस्कशन फॉर द हिस्टोलॉजी अगर तुम लोग को कोई प्रॉब्लम हो. तो ये चीजें तुम लोग नोट डाउन कर लेना. अगर तो जो नेक्स्ट जो भी रिवीजन सेशन होगा प्रॉब्ली स्टमक के साथ करेंगे, तो आई विल आल्सो गो थ्रू द हिस्टोलॉजी इन डिटेल इफ यूड लाइक दैट. सही है. असल में हिस्टोलॉजी में इसलिए ज्यादा फोकस नहीं करता कि वो यूजुअली वो तुम लोग के बहुत ज्यादा काम आती नहीं है, सिर्फ थोड़ा समझने के लिए इंपॉर्टेंट होती है. बट स्टिल इफ एनी ऑफ यू आर इंटरेस्टेड, so I'd be very happy to help you out in that matter. Any other questions? बहुत तेज तो नहीं आ रहा क्योंकि previously कुछ बच्चों को कंप्लेन होती थी कि मैं बहुत तेजी से गुजर जाता हूँ. So if you think you have a problem, कोई चीज समझ में नहीं हो तो please feel free to ask me. सही. So I'll be uploading a short quiz, MCQ based quiz होगा. ज्यादा नहीं, बहुत लंबा चौड़ा नहीं होगा ऑब्वियसली क्योंकि टॉपिक हमने बहुत कम की होती है. बट मैं तो एक बात ये क्लियर कर दूं कि जो मैं सवाल पूछूंगा वो सिर्फ मेरे लेक्चर से नहीं होंगे. यू विल हैव टू गो थ्रू द बुक वंस अगेन. इट इज माय लेक्चर्स आर नॉट अल्टरनेट फॉर बुक्स. रॉबिन्स जो बेसिस ऑफ पैथोलॉजी है, आई विल अपलोड द सॉफ्ट कॉपी आल्सो, ताकि किसी के पास ये बहाना ना बचे कि मेरे पास बुक नहीं थी. यू प्लीज गो थ्रू द रॉबिन्स. हाँ, I will upload it on Edmodo. सही है, don't worry, ताकि everybody can get it. Any other question? किसी और को कोई query हो, but please एक go through Robin से जरूर कर लेना. Revision के लिए you can choose to go through pocket Robins. तो because वो you can easily collate the large big Robins with the pocket Robins, तो revision आसान हो जाता है. Any questions? ओके युसरा, मेरे ख्याल में टाइम भी हो गया है और फिर इंशाल्लाह अगर कोई क्वेश्चन हो तो.
जी सर.
जी, आई बेग योर पार्डन.
यही फर्दर कोई क्वेश्चन है नहीं लोग.
हाँ सही है, सही है, सही. थैंक यू बेटा. हो तो मुझे you can always post it to me. Okay, yeah. I'll be uploading this lecture also and the Robin's copy also on Edmodo hopefully. Thank you, sir.